The information shared on the Sky Women's Health podcast is for educational and informational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with any questions you may have regarding your medical condition. Never disregard professional medical advice or delay in seeking it because of something you heard on this podcast. Reliance on any information provided by Sky Women's Health, Dr. Carolyn Moyers, or any guests featured on the podcast is solely at your own risk.
You're listening to Sky Women's Health Podcast, your evidence-based resource for women's health and wellness, exploring the holistic principles of osteopathy, integrating mind, body, and spirit, designed to empower you as your own healthcare advocate and help you live your best life. I'm your host, board-certified OBGYN, Dr. Carolyn Moyers.
Welcome back to Sky Women's Health Podcast. I'm your host, Dr. Carolyn Moyers, board-certified OBGYN, menopause certified provider, and ISSWSH fellow. I'm a passionate advocate for women's sexual health. This is not anything that I learned in residency. This was continuing medical education. This was getting involved in the International Society for the Study of Women's Sexual Health, taking courses, reading books. This is how I've learned this information. And so when I came across the International Society for the Study of Women's Sexual Health Process of Care for Hypoactive Sexual Desire Disorder in Women, that was published in the Mayo Clinic proceedings in April of 2016, I just thought, let's talk through this. This guideline is really gold standard and helps clinicians kind of navigate one of the most common and under-discussed sexual health concern among women, low sexual desire. What does hypoactive sexual desire disorder actually mean, though? Is it just low desire, or I just don't feel like having sex? It is the most prevalent female sexual health problem. So I think it's really important for us to well define. It's considered a persistent or recurrent lack of or absence of sexual fantasies or desire for sexual activity with marked distress or interpersonal difficulty. So is this causing grief or a discord in your relationship that's not otherwise accounted for by general medical or psychiatric conditions, right? So we have to kind of peel back the layers as to what might be going on here. It can be defined, as primary or secondary. Has this always been the case, or is this something that's developed over time? Is it lifelong or acquired? Is it in particular situations? Is it with every partner you've ever had, or is it just situational? Are you able to orgasm alone, or is it only in partnered sex where you're unable to orgasm? All of these kind of details are important in your sexual history. The broadened definition of hypoactive sexual desire disorder can include a lack of motivation for sexual activity, either by reduced or absent spontaneous desire, so those thoughts and feelings or fantasies around sex, or reduced or absent responsive desire to erotic cues, and or stimulation and inability to maintain desire or interest throughout sexual activity. Another component is loss of desire to initiate or participate in sexual activity, including behaviors such as avoidance of situations that could lead to sexual activity. That's not necessarily secondary to pain with sex and is combined with clinically significant personal distress. Again, is this creating frustration, grief, a feeling of loss, sadness, depression, incompetence? Women with HSDD often have impaired body image, self-confidence, self-worth, and feel less connected to their partners. Why this matters: a new study published in Menopause, which is the Menopause Society's publication for members in May of 2025, highlights a persistent gap in sexual health care, despite both OBGYNs and general practitioners acknowledging that sexual health is essential to a woman's quality of life. The conversations around it are often missing from routine care. The most cited barrier to that was short appointment times. There's only so much you can do in 10 minutes in the standard clinical setting. Other factors include discomfort with having those conversations, lack of training in sexual medicine, and beliefs that sexual concerns really aren't a priority to that appointment or to that visit. Notably, general practitioners reported these barriers are more frequently than OBGYNs, right? So OBGYNs are going to be much more comfortable having these conversations because we deal with sex all day. But older physicians showed more reluctance in having these conversations. The study just reinforces the importance of continuing education to build clinical confidence. And it really underscores the need for us as women, as health providers, to make space in our visits for sexual health concerns and giving permission to talk about this change in a patient's life is really, really important. And for patients, I would encourage you to simply bring up the topic. Patients are often really uneasy about having these conversations. And when they do share, I generally just encourage that conversation and say, thank you so much for trusting me with that information. Let's talk about, how this is kind of played out in the, since symptoms presented, what's most bothersome to you, etc. So giving permission, opening the door. So this is one of the first steps in the ISSWSH process of care is just opening the door and giving permission, creating space where women feel safe, seen, and heard. And this is probably one of my favorite things about Sky Women's Health and the practice that I've created in Fort Worth, Texas, is when I hear patients tell me that they feel seen and they're so glad that they felt heard finally, it just brings tears to my eyes because this is what we're here for. This is why we created this. It's important to affirm that low desire isn't just normal aging or something to live with. It can really impact intimacy, self-esteem, and relationships. And many women don't bring it up. They're often waiting for us as providers to open the door. And so we can simply start by saying many women experience changes in sexual desire at different points in life. If that's ever a concern for you, I want you to know that you can talk to me about it. One of the most common screenings that we do at Sky Women's Health is decreased sexual desire screener, and it is on my new patient form, so everybody is filling this out. And it's basically 5 simple questions that help to assess the presence of low desire, how distressed we are about it, and the onset and the context of that. Is this lifelong or is this something that's acquired over time? Is it in every situation or is it specific situations? Is it in every encounter or in specific scenarios? So all of this helps us to kind of objectify those symptoms and get into deeper conversations about what might be going on. So, one of the first things that we have to do once we open that door for conversation and have the discussion and found out what's going on is a physical exam. A comprehensive pelvic and musculoskeletal exam is really critical for evaluating the potential contributions to decreased sexual desire. What are we assessing on that exam? We're looking at the clitoral health. Does the clitoral hood adhere to the glans clitoris? Is there phimosis? Is there atrophy? These things can impair sensation and arousal. The urethral meatus, is there prolapse of urethral meatus? Is there incontinence? Vulvodynia, we're looking, is there chronic pain or pain to the vulva with no lesions that can make sexual activity painful and distressing? And this is typically done with a Q-tip test. So with a small Q-tip, I start across the mons, work my way down the labia majora, the labia minora, and then around the introitus as if it is a clock. So starting at 12 o'clock, touching with the Q-tip around the opening of the vagina at that introitus and assessing where does it hurt, if anywhere. Is it creating pain, burning sensation, etc.? We're also looking at the labia to see if there's any resorption. So with low estrogen state, the labia minora start to resorb. They start to just kind of become flush, disappear. You can almost see the outline on the labia majora where they once were. And obviously, this can create more discomfort, more friction. We're also looking at vulvovaginal atrophy. But before I even put in a speculum, I'm doing a digital exam. So I'm looking for high tone pelvic floor dysfunction, These hypertonic muscles can lead to pain with penetration and altered sensation, oftentimes because it's creating inflammation and decreasing blood flow to the pelvic organs. And that can simply be done by starting at the ischial spine and kind of moving around again, just as if it's a clock, touching those pelvic floor muscles and assessing where. You don't have to know specifically the muscle that you're touching, what it is and how to define it, etc. That may not be your cup of tea. You may not have learned that, but you are aware of the anatomy and you can at least direct them to a pelvic floor physical therapist, indicating that they have left-sided pelvic floor tension and pain with palpation. All right. And so we're also looking at the vulva to see if there's any evidence of skin conditions, dermatosis. So something like lichen sclerosus, lichen planus, eczema that can cause itching, pain, and scarring. And those may require a biopsy. So the last thing that I do as part of an exam is a speculum exam where I'm looking at the vaginal tissue. Do we have inflammation? Do we have discharge? Do we have a lack of rugae? So are we losing the folds to the vaginal epithelium? Or is the vaginal epithelium thinning? These are all things that we're paying attention to. We want to rule out any infectious process. So often patients come in thinking that they have either a yeast infection or a urinary tract infection, and we do a vaginitis swab and actually find out that it's bacterial vaginosis. And so we want to make sure that we're really assessing what's causing this discomfort, lack of desire, et cetera, because it can be multifaceted. Okay, and then pudendal neuralgia. And this may be one that you have not thought about, but the pudendal nerve innervates the pelvic floor and the clitoris, and neuropathic pain of the pudendal nerve can mimic or cause sexual dysfunction. Lumbosacral spinal pathology, herniated disc, and spinal stenosis can contribute to decreased sexual desire, decreased responsive desire, decreased arousal from nerve impingement. So, assessing these findings often can go undetected if we're just putting a speculum in or if we're just looking at the vulva. So a really comprehensive exam is important. And many women have never had a focused genital exam that prioritizes sexual function. So they're often shocked whenever this type of exam is done, but very grateful. And one of my best tools for this type of exam is a mirror. Seriously, a large mirror that I ordered off of Amazon that staff holds at an angle so that the patient can see their vulvar anatomy as we're doing the exam and can identify, oh, that's what the clitoral adhesions look like. And you may be asking yourself if you've never had clitoral adhesions or you've never seen that. Essentially, the clitoral hood adheres to the glans clitoris, and we have natural sloughing of tissue that happens. So we have a buildup of smegma underneath that. And we can also develop keratin pearls that create irritation and discomfort, not to mention just simply a muted orgasm if it's just in hiding. All right. And as we continue to think about hypoactive sexual desire disorder, we want to also take into consideration what medications and medical conditions do we have that could be contributing. So, what are some medical conditions that might contribute to sexual function? Thyroid disorders, diabetes, cardiovascular disease, endometriosis, chronic pain syndromes, depression, and anxiety. And let's not forget medication. Some of the most common culprits in decreased libido can be SSRIs or SNRIs. If you have this response to your antidepressant, we may want to look at another drug that maybe has less side effects. So some of the medications for depression that have the lowest rate of sexual side effects can include Wellbutrin or bupropion or Cymbalta, duloxetine, as its generic name. Also, antihypertensive medications can affect sexual desire and oral contraceptives. So, in some individuals, oral contraceptive pills can impact sexual function. It's not all, but in some, it can affect libido, arousal, and lubrication. Research shows that some hormonal contraceptions, especially those with that lower levels of androgen, like testosterone, can reduce sexual desire. One large study found that 43% of women using hormonal birth control reported lower desire compared to only 12% using non-hormonal methods. This may be due to how the hormone in the oral contraceptive pill specifically affects the body's natural sex hormones. Pills lower estrogen or certain progestins and can cause vaginal dryness and affect arousal and orgasm. While not all women are affected by this, those who are more sensitive to hormone changes may notice a decrease in sexual desire while using these methods, specifically because an oral estrogen raises your sex hormone binding globulin, which binds up your testosterone. And again, not all individuals are susceptible to this, but some on oral contraceptives are. And so we have to talk about what might be a better option for them if we're wanting to prevent pregnancy or we're wanting to control cycles so that we do not have this effect. Another medication that can affect sexual desire is opioids and then antipsychotics. Now, obviously, you're not going to make any of these adjustments without talking to your psychiatrist, psychologist, and really having it be a multidisciplinary approach. All right, psychological factors. Sexual desire is complex, right? We've always talked about there being a biopsychosocial component. The psychological contributions are significant and can cause relationship strain. Body issue concerns are definitely one that limit women wanting to show up in that way. If they are having all of these thoughts about their body changes around the menopause transition, that can be a really hard one. Past sexual trauma is another one that definitely can affect sexual desire. Stress, fatigue, caregiving roles. Sometimes women are just touched out or just too tired to engage. And then mood disorders, depression absolutely affects sexual desire. So it's important to screen for anxiety, depression, and past trauma as part of a routine evaluation for low sexual desire. All right, what do our treatment strategies look like then? Well, it's really going to be multimodal. It's going to depend on what's the underlying cause. Our brain is our largest sex organ. So, one of the first things is education, reassurance, addressing relationship and psychological concerns, whether that's sex therapy or counseling, pelvic floor physical therapy for muscular dysfunction, vaginal estrogen for genitourinary syndrome of menopause, androgens or testosterone therapy, which is off label use for hypoactive sexual desire disorder. And we do have FDA approved drugs, which are filbanserin, which is Addyi, which is a nightly oral pill that is taken every night. Most common side effects with that are drowsiness, some nausea, lower blood pressure, very mild, minimal symptoms with this, though. It's a very safe drug that can be used in combination with other drugs. There's about 60% of patients who respond with this. It really takes about a 6-month trial. Same thing with testosterone. We know that testosterone is indicated for low sexual desire in postmenopausal women. And it really takes consistent use over many months and us monitoring your testosterone level, making sure that we're staying in a female physiologic range. We don't want to be in a super physiologic range because that has its own set of side effects. So we want to make sure that we're being careful with these therapies and really monitoring, does it impact your treatment and how you're feeling? Vyleesi is another one, or bremelanotide is the name of the medication. That's Vyleesi, which is an injectable on-demand therapy for hypoactive sexual desire disorder. So knowing that there are therapies, I think, is very empowering, but it's very specific to the patient and what is the underlying cause. If it's a relationship issue, no amount of medication is going to fix that. If it's a pelvic floor issue or changes due to estrogen deficiency, such as genitourinary syndrome of menopause, we have to address those specifically. Or if it's lichen sclerosis and an actual skin disorder that can cause progressive scarring over time, we have to get ahead of that and treat that so that there is comfort there, because we don't desire painful things. All right. And one of the last treatment options is the behavioral strategies. So, focusing on sensual exercises, mindfulness, scheduling intimacy, really making time and space for that is important. Most importantly, really partnering with the patient and provider. Like, this is really important to find that right combination of interventions and bring your partner, your sexual partner, into the conversation, oftentimes is very helpful. So, sexual health is health. It's integral to quality of life, to well being. There are tools, there's science, there's screening, and a lot of empathy that needs to go into having these conversations and helping you to reclaim your desire. But it really starts with having the conversation, giving patients permission. I'm here, I'm ready to talk about this. Now, if you bring this up and your healthcare provider shows discomfort or doesn't have answers and is uncomfortable having these conversations, go to the International Society for the Study of Women's Sexual Health website and find yourself a provider on the ISSWSH website that can help you to address these concerns. Thank you for listening to Sky Women's Health Podcast. If you found this helpful, please share it with a colleague, a patient, a friend, and don't forget to subscribe for more conversations that empower women to live well, feel well, and be well. Until next time.